panel discussions are innovative. It's a great benefit for anyone who takes the time to attend this meeting.
And there was a very practical handling of how to use imaging, how to make interpretation.
Also, it touches various topics, both on the coronary and structural side. Very insightful, exchanging scientific data and results of trials.
Several live cases have been performed to show complex, innovative procedures. Several workshops were Here we move forward to the next session, and we are going to see some live presentations now, so that's where we go. Can I invite the moderators, Dr. Ajit Mullasari, Dr. Sasko Kedev, Dr. Abhishek Raj Popat, Dr. Amrish Satwik, Dr. Ajay Yadav, Samir Dani, you got it here. Samir, please join us. Ajay, come over. Dr. Manish Kapoor, Manju Bhargav, Manohar Shinde, Pawan Suri, Dr. Chandramani Adhikari, Dr. YKT Bhattarai, Dr. Nishit Chandra, please. So, are we ready to go live? So the first live case presentation comes from Dr. George Joseph from CMC Vellore. So we are going to follow a pattern where George is going to initially introduce his case and tell us what he's planning when we move over to Dr. Praveen Chandra at Medanta Hospital to do his presentation. So over to George. George, can you hear us? Can somebody check the audio and then... So it looks like George has already done quite a lot of work over there. Hello, George?
Hello, Matul. I can start because I'm ready. So in case you are not getting connected.
Okay, sure, Praveen.
Yeah.
So maybe if the audio is not connected till then, we can go over to Dr. Praveen Chandra, right? Can the AV switch over to Medanta? There we are, Praveen. We are live with you. Yeah.
Okay. So thank you, Atul, for this last minute juggling. And so as you already, everybody knows that there have been some new changes in form of new regulations for live cases. So we at this moment chose to do it a case in a box. And here I'm going to share with you in this meeting the interesting case. But I'm sure very, very experienced people are sitting here. For them, it may not be so much, but definitely we were quite excited to do this case. So this is a patient who was actually a not so old patient. He was brought to us in a severe respiratory distress, and he was having renal failure. He was having severe mitral regurgitation. He was having some degree of pneumonitis. So all that was coexisting, and he was not able to kind of come out of this. So he was airlifted from a different city. And then we tried to, kind of manage him medically, but the infection got settled, but he was still in failure. And he was completely in hypotension, and, the output was very low. So we did, kind of examine him. A transesophageal echo was also done. The severe MR, and with the ruptured chordae, with flail P2 with anteriorly directed jet, and akinetic, LAD territory, and the EF was about 20% or so. So we put him on a balloon pump, on ventilation, on elective basis, and then we decided, okay, and he was, dialyzed a few times before this. So we, did his angiogram before we take him for a, final mitral, regurgitation treatment. And here we found that there is also severe triple vessel disease. So this was the, disease. As you can see here, the LAD, the circumflex, the OM, everything was quite bad. So we thought that let's quickly, since he's already on dialysis, why not, just, quickly try to open it up. So we did the intervention and everything was okay. The intervention went well and we could achieve good TIMI-3 flows in all the 3 arteries. And then after that, we decided that we will go ahead with the mitral clip procedure, because the mitral regurgitation was absolutely incessantly severe, and it was mainly because of the the ruptured chordae, which was leading to a prolapse of the posterior mitral leaflet with a very anteriorly directed jet.
This is a 57-year-old male presented to this hospital.
So as you can see here, that we are in the hybrid cath lab, and we have chosen to take this patient now. He's still on balloon pump. He is on ventilation. Of course, all these patients have to be under GA. And so now the plan was to do the mitral clip. And of course, the challenge was that this was a very sick patient. It was a ruptured chordae and ischemic situation, which is definitely a high-risk situation and not a very good. So generally, we say that take these patients only once you have done about a good experience of functional MR and also the degenerative MRs of some varieties. So you can see this in the transesophageal echo, which is being done, that the PML is prolapsing the P2 segment and the jet is anteriorly directed. In this view, it is not seen that much, but definitely it was quite significant because it was a very eccentric jet. And this is the P2 prolapse. You can see 3D imaging, and also you can see the chordae, which is being seen over here, which is a ruptured chordae. So with this, we started, and you can see that the chordae is just jumping inside in this view, and the prolapse of the PML is seen, and the jet is very eccentric jet, and the gradient was quite okay. So there was no gradient at all. So this was a good, situation in any case. And we decided that, okay, we'll go ahead with the XTW, clip over here. And this is the puncture we are doing. And the puncture was also a little difficult because, definitely the segment of, where we wanted to puncture, we were only getting a height of about 3.5 centimeters. And we finally accepted that. And at that place, the septum was not getting punctured through this needle. So we took a cautery with a wire on inside this, opposite end of the coronary wire, and we were able to puncture it. And then after that, we exchanged it with a Emplart's wire, and on this Emplart's wire, we took this. I'll just show you quickly. Move a little bit faster. Here is the puncture which is happening, and then and you can see that the patient is already on balloon pump. There is a a neckline here which is for the dialysis. So everything was quite and being done in a very sick situation. And here is the multi-purpose catheter, and we put the wire, which is the Emplart's wire. So we always position the SGC on the Emplart's wire because it is a very high caliber catheter, and you can see that we are able to now take it inside, checking it in the TE. So TE is continuously, you have to monitor that so that you don't hit anywhere into the anatomy, otherwise it can sometimes rupture also. LA ruptures can happen. And if you hit the LA appendage, you can even rupture the LA appendage very quickly. So be careful. And you can see that now the clip is coming in. It is touching the anterior, it's quite anterior. So we made it a little bit posterior by moving this, the catheter over here. So this is how we are doing it. And now we are checking the clips, the grippers. Once the grippers were checked and the orientation was also checked, we are checking the orientation, the anterior posterior, and also the clocking, which is very, very important. So here you can see that we are trying to come into the middle and also go a little bit medial because the jet was coming a little bit medially. but we were not actually getting a good grasp because there was a little bit tissue which was like missing over there, something like a cleft leaflet. Actually, it was not cleft, but the tissue was missing, so we were not able to grasp it. But then we got a good position. We are trying to position it, and you can see that once we get a good position, we grasp it and check it again in all the views, the bicommissural, and also the LVOT view, and also in the 3D view. So this is the orientation is slightly 11 o'clock. We are making it 12 o'clock, and with that we were able to get a position here. But in this you can see that we were able to grasp the posterior, but the anterior was missing. So again we left it and tried to grasp it, and then finally we were able to get a very good position here. And you can see that the grippers are jumping. So once the grippers are jumping, that means you are getting a good amount of tissue of the leaflets. Because sometimes if you don't get a good amount of tissue, then SLD can happen. The leaflet detachment can happen once you release it. So once we check everything, good grasp, and in all the views, then now we are trying to release it. You can see that he has taken the pin and releasing the exposing the groove. And once the exposure of the groove is done, then we rotate it 8 times, and now we have released the clip. So you can see that the clip is released. It is very stable, and then very carefully we have to take it out. We are taking the clip delivery system out, and then we'll reassess what is the situation. Do we need another clip, or we just leave it like that? So here you can see that we are trying to visualize now that how much is the MR is and how much is the residual gradient. So based on that we will take a decision. So the clip is very stable, and there is a very small MR. The MR is very little, so we can even leave it like this, but we were checking everything and we found that the gradient was very less, and there was a leak which was happening from the medial aspect of this clip. As you already saw that there was a prolapse in this segment which we were still seeing. So we said, okay, let us try to see if we can get a good position and a good clip with the second clip. So we took the second clip at this stage, and because now the endeavor is to get as minimum MR as possible on the table, because many times when you leave these patients, they go back off ventilation and then the MR goes up. So we said, okay, and this will also, once we put the second clip, it will stabilize the second clip also, because there was a issue of that, the prolapsing segment. So we took a second clip. You can see that the second clip is come in. We are going medial. So in the RO position, any clip which is going below this clip will be medial, and above it will be lateral. So in this view, bicommissural also, you can see that we are going medial. And here also you can check in the LVOT view that we are at the segment where the leak is happening. We are checking in the 3D. So we have to keep checking in all the views before we finally go inside the LV. So we checking the clocking looks okay. But with this clocking, we were seeing that there was some degree of a misorientation. So we again clocked it more, and now you can see that it is completely oriented. The orientation looks good, and then we check the grippers, and then go inside with a 30 degree, almost a 30 degree open clip. And with this, we are inside the LV, and we are trying to now grasp it. See, we are able to grasp the anterior leaflet, which is the gripper is jumping, but the posterior one is not so sure. So we were not so sure that whether this one is very good leaflet, length has come in the grippers or not. So at this stage, we again repositioned a little bit more, did some more clocking, and after that, we could get a good grasp. You can see that now we are getting a good leaflet dropping on these two arms, and so you can see that we were able to get a good grasp here. And with this, we check in the 3D also, seeing that it is almost sticking to the first clip and very good position. So with this, we leave it here, and you can see that the leakage is also reduced a lot, and very stable position we can get in this. You can see that it's just sticking to the first clip. So with this, we will release it here, and once we release it, we find that there is a very minimal MR. I think it is between the two clips, which will go away because there will be some fibrosis which will happen, and finally this will be okay. So with this, we were able to actually finish this case in 18 minutes actually. But and now we are doing a figure of 8 stitch. With this, you can see that there is a balloon pump on the side, which is the arterial. IBP is on the same side, and then we finally shifted the patient back, and now the patient is doing okay. So with this, I stop here. Maybe if you have any questions or any clarifications, thank you very much. I'll stop sharing now. Okay.
Praveen,
Thank you.
good morning. Ajit here.
Yeah.
Very nice demonstration. Just a few questions. So this is a difficult case, not the ideal. I saw you do not have a left atrial pressure monitoring during the case. Do you keep a pigtail? Because it's a G3, we don't
No,
have
these
it.
days we don't, because we do not have to keep a pigtail, because there is now a port.
Yeah.
In the catheter itself. You can keep doing the monitoring
Yes.
through that port also. So the pressure, earlier we used to keep the catheter inside, but
Yes.
now there is no need to do that. If you want to do LA monitoring, you can do it with this. Otherwise, typically now the pulmonary venous waveforms can be measured before and after, and then you can assess.
Yeah, that's true for the medal system, but the G4, I'm not sure whether you got it yet in your lab. The other question I have is, this is a very tricky situation where you have to get a medial clip correctly in. And when you were putting the second clip, what are your indications? Well, one is an MR, which is grade 2 and above. Is there anything else that you look at? Because sometimes you can land up damaging that leaflet and get a cleft or a leak after you put the second clip. So is there some ways? You're very experienced.
Very good question. Very good question, Ajit. The indication of second clip is, one is that now the endeavor is always to get as best minimal MR as possible. Earlier we used to say 2+ is okay, but now we say that 2+ is not okay. We want less than 1, and that's what the endeavor is, and we have to do it very carefully. As you said already, there is a chance that you can get entangled into the chordae also. So you have to be very careful, especially if you're on the medial side. So most of the times when we put the second clip, it is on the lateral side. But here the situation was totally different. So that is why otherwise the second clip was always a lateral clip for us. But here, because of this peculiar anatomical situation, we have to do that. And the second is, we were very careful that we don't start clocking too much, otherwise we'll get complete entanglement, and then it can damage the whole thing. The third is, the indication of putting a second clip is in degenerative bileaflet prolapses or very bulky leaflets. There even if the MR is less, and if there is the gradients are good, like less than 3, in this case it was 2, so we put clip on the lateral side to stabilize the first clip, because sometimes the clips can have a detachment maybe within first 24 hours. So these are the usual indications of doing a second clip. And the second clip is always a thinner clip, mostly because here you saw that the first was XTW and the second was XT, which is a thin in the width, but it was a long clip because we wanted to grasp it, because initially we saw that the posterior leaflet may not come, and that is why we took. Otherwise we could have taken an INT also.
I think a lovely case, and I'm sure that this patient, you could wean off the pump and get him off the support, because these patients dramatically improve, and we have done a few of them in acute severe MR post-MI, where the surgeon doesn't want to go in because there's a stent or the patient is sick, and these just get 1 or 2 clips and they come off beautifully after that. So I think this is a tremendous indication, apart from chronic degenerative MR, which is another a chronic MR, which is a ischemic MR with dilation. I think acute MR is something which we need to is a growing indication in patients, especially who are on support and are who are in shock. Any other comments from my colleagues? Yeah.
Yeah, I think it is one of the indications where there is a very good reward also, as compared to patients who have LV dysfunction and MR and we do the clipping. Now, what would be the restenosis, chance of mitral stenosis if you put more clips in these patients?
Yeah. So, Yadav, very good questions. Basically, this is something which we have to keep in mind where we are doing it, especially in very thickened valves, or if there is a gradient from the very beginning. So we have to always check the baseline gradient. So in this case, there was no gradient, but in some patients there is a baseline gradient of about 2 or 3 or something like that. And in these cases, we have to be checking the gradients after every deployment. So if the gradient goes above 4 or even if it goes above 5, then definitely there is an issue. But above 4, we can grasp, check the gradients. If the gradients are going up, take out the clip, don't leave it. And if the gradients are going up, even with the first clip, because first clip also can lead to gradients, then also you have to be judgmental about the whole thing, whether you want to leave the clip behind or not. Yeah. So gradients is very important before we leave the first clip or the second clip or the third clip.
So big
thank
hand
you,
for
Praveen.
Dr. Praveen Chandra.
Yeah, thanks, Praveen, for an excellent presentation. Interest of time, we'll go on to George. I think is ready in the other lab. So, George, can you hear us?
Sir,
So-
our audio is on, sir.
Yeah, so they can play the first part.
Yes, sir. Yeah, like yes.
So George, you're live, and would you like to introduce the case that you're showing us today?
Morning from PMC Vellore.
Can we increase your volume a little bit? Yeah.
I have to first introduce my team. Very soft. Increase the volume. Dr. Vijay Samuel, Professor and Head of Department. Dr. Lokesh, who's a consultant focusing on aortic interventions. Dr. Girish, our Fellow in Peripheral Interventions. And from anesthesia, we have Dr. Ilango, and our technicians, Mr. Bhaskar and Ms. Lima, and nurses, Shamla, Steffi, and Vanilla. So today we have a interesting case, and I'd like you to see the case details. So we need to bring up the slides. Can we have the first slide, please?
We can see the slides. Yeah.
So that should be visible to the audience. Now, go back, you've gone to the second slide. Okay, so this is a 64-year-old male who has multiple risk factors. He's a smoker, dyslipidemic, hypertension, and he was incidentally detected to have a distal aortic arch aneurysm, which was actually a penetrating aortic ulcer during evaluation of an unrelated problem. And that evaluation also showed a abdominal aortic aneurysm, which is less than 5 centimeters in diameter. And the pressing problem that we felt was the penetrating aortic ulcer. So next slide, please. So this is the cross-sectional CT image. You can see the penetrating ulcer in the arch, which is projecting anteriorly and to the left with a thrombus lining it. Next slide. And this is the measurement of that penetrating ulcer in a sagittal view. It's quite big, 5 centimeters in one dimension, almost 4 in another. Next slide, please. So this is the 3D reconstruction of the entire aorta. And you can see the penetrating ulcer. Next, press the next button, please. Yeah, so that marks the penetrating ulcer. Here we're seeing only the lumen, so it doesn't look as big as it really is. And the arch is otherwise kind of a standard arch. We have some atheroma all over the aorta from arch downwards, and some places it's quite protuberant, which you see better on the axial images. Next, please. So this is the abdominal aortic aneurysm, which is, as I said, sub 5 centimeters. So we're leaving this alone for the time being. and we'll deal with it if it increases in size later on. Next. These are the femoral arteries. Common femoral arteries are good sized, almost 9 millimeters in size. So we don't anticipate too much difficulty in getting our main endograft delivery system in. So we are choosing the right common femoral for the main axis. The next slide. And this is the measurement of the ascending aorta in the mid part, which is about 40 millimeters. So we need an endograft that is starting off at least 42 millimeters. And the descending aorta is significantly smaller. It's only about 30 millimeters. So we need, we have this disparity in size. So a 42 would be actually too big for the descending aorta. The next slide, please. So these are the measurements we usually take. So we have measured the outer curvature of the arch, and we can see that 150 millimeters or 15 centimeter long graft may be sufficient to cover this aneurysm. We'll start in zone 0, a little ahead of the innominate artery, and end in zone 3 or zone 4 maybe with this graft. And so we're choosing 150 graft, and it will start 42, but it will taper down by 4 millimeters. Next slide, please. So this is the superior aspect of the arch, which we have shaved off the 3 arch branches, and we are seeing the ostia of the 3 arch branches. Innominate is below, left carotid is in the middle, and subclavian is on top of this image. And the red line you see is an imaginary 12 o'clock line. And we see the relationship of these ostia to this 12 o'clock line. And we also measure the distances between the 3 ostia. So you can see in small letters the distances between the 3 ostia. So we have something like a triangle there, which we have to replicate on the graft. Next slide, please. So this is our worksheet. So you can see the 3 fenestrations there. You can see the distances between the 3 ostia, and the 12 o'clock line is down the middle over there. So we're going to make 3 fenestrations in our graft, and the diameters are innominate 9, left carotid 7, and left subclavian 8. And we're going to cuff 2 of them, that is the carotid and subclavian, because that is bang over the PAU, and we want a better seal there, so cuffing a fenestration gives us a better seal. And we're also going to have a wire loop going from the left carotid into the left subclavian fenestration, and both ends of this loop will come out of the endograft sheath, delivery system sheath, and then the 2 ends will be out of the femoral artery once we have finished deployment. Okay, so next slide, please. So this is a video of our deployment. I'm making the fenestration on this graft. I don't know if it will run. Can you run this video? Will it run? Yeah, so we have a circular fenestrator, which we heat over a spirit lamp, and then we mark the point in the graft where we want the fenestration, and just touch it with this heated fenestrator, and you get a perfectly circular fenestration with the edges are all heat sealed, so there's no fraying of the edges. Then we take nitinol wire, radiopaque, and suture it with 6-O-proline. And you saw the completed graft later. So here we are making the 3rd of the fenestrations, that is the subclavian fenestration. All right, we'll next. So now we'll video of that. So this is the graft that we prepared. It's a 42 mm to 38 mm tapering graft. It's 15 centimeters long, and you can see 3 fenestrations made, Press the next button, please. So those are the two cuffed fenestrations for the left carotid and left subclavian, marked in red arrows. Next. And this is the looped wire. It's a road runner wire, nitinol wire, which loops between the left carotid and left subclavian fenestration, and both ends come out of the back end of the graft. They go through the sheath and then come out of a needle hole in the sheath. So they kind of trail the delivery system from the groin as we go in. And once we remove the delivery system, this wire loop will remain and it will help us to cannulate the fenestrations. So that is the wire loop. Next thing, and then we have a radiopaque marker, which is like a figure of 8. It's right there on the endograft, which we take it off and refix it in this position. So that's the 12 o'clock position. So when we look at it under fluoro, this should be on the outer curvature of the aortic arch when the arch is maximally opened out. So it will look like a straight line rather than a figure of 8. So that is to get us the correct rotational orientation of the graft before we deploy it. And then next one, please. We also have a kind of a dot marker, which you can't see very well. It's fixed at the back end of the left carotid fenestration. So that is to help us position the graft in the correct axial position along the axis of the aorta. So that dot will line up with a marking wire in the left carotid. So then we know that the axial position is correct. So if we get these two right, the rotational orientation and the axial position, then we are good to deploy the graft. And then we start pacing and deploy the graft. So next, please. I think that's the last slide. So I'll stop at this point and then be happy to discuss this case.
So thank you, George, for introducing the case. Ajit here.
Okay, so we are now into the case. We have taken all the axes. So the main axis is the right femoral artery. With ultrasound guidance, we punctured it and we put 2 ProGlide sutures at 10 and 2 o'clock. Then we later have converted it into 18F sheaths, which we will remove before taking the delivery system in. Then in the left groin, we have a femoral arterial line 4F just for pressure monitoring. And there is also a venous line for pacing. So we have set up pacing and we have RV pacing. So if you can show the screen, you can see the setup that we have got. Is the screen visible? Yeah. So the fluoro is on. I don't know if the screen is.
Yeah, we can see it. We can see it, George.
Okay. So no, you can just record it. Okay, just stop. Yeah. So what you're seeing on the screen now is 3 things. One is you can see the RV pacing in the bottom left. So that pacing lead is going through a 8F sheath, and that sheath is stabilized by a wire, O18 wire, which is in the PA. So the wire stabilizes the sheath and the sheath stabilizes the pacing lead. So we want stable pacing during our arch endograft deployment. That's why we do this. And then you can see there is a wire coming down from the left carotid and going out into the left arm, and that is the marking wire. And this is our O35 thermo wire. And then you can see the Lundquist wire, which is in the ascending aorta. And once we got this, we do the angiogram. So let's play the arch angiogram. So you can freeze it when the image is good. So this is the arch angiogram. So the working view for this case is LAO 62 degrees. And that opens out the arch maximally. So the way we figure that out is, before this, we go to the RAO view where the ascending and descending aorta overlaps. Is it possible to show that plane of the arch? Yeah, so this is the plane of the arch. You can see there's a catheter with a stiff wire going up the aorta and going into the ascending. So the descending and ascending parts are overlapping. So this is in RAO 28. So we go orthogonal to this. Now go to that arch image that we saved. So this is now LAO 62 degrees. So in this, we can see that that marking wire is telling us where is the left carotid posterior margin. And that is over the ET tube also. So we have two landmarks as we are deploying. The left carotid penetration should be just ahead of that marking wire. And in this view, that figure of 8 marker, which is in the outer curvature, should look like a straight line. So when we're going in with the delivery system, this figure of 8 should look like a straight line, a thin straight line, rather than an 8. Then we know rotational orientation is correct. So then once these two are achieved, we pace and deploy the graft. So we are all set now to proceed with the arch endograft deployment. So we are now ready to take the delivery system into the arch. And if you look, you can see that figure of 8 is now on the outer curve like a narrow straight line. And then you can see a dot. That dot is the posterior limit of the left carotid penetration. So that dot should be ahead of that marking wire. And this figure of 8 should always remain like a straight line. So now I'm entering the arch, and I'm looking mainly at that figure of 8.
You have to
I'm trying to keep it like a straight line.
The penetration
It
canalus.
may change a little bit as you enter the arch, but as long as it is by and large a straight line, it's okay. Some change. It's instead of a thin line, it's become a thick line. But I think we are still all right. Should we? I could. Okay, let's see. I'll go in a little more, and so you can see the dot coming up. The dot is now just So now the rotational orientation is satisfactory. I'm not totally satisfied because it's not like a thin straight line, but it's okay. And the dot is in the correct place. And you can see all the fenestrations are towards the outer curve. So I think we'll accept this. So at this stage, I have the left carotid pressure and the femoral artery pressure on here. And the anesthetist has the right radial pressure, and they're all about 95 to 100. So we can keep the pressure a little up. Okay. So after we deploy again, all three should be the same. That will tell us our fenestrations are lined up correctly. So with the initial part of the deployment, we don't pace. I'll just deploy the free flow and the first covered stent before starting to pace. So now I'm focusing on that dot, which is the posterior limit of the carotid penetration. I'm a little ahead, but I can come back if I want. Okay, so now we are sort of ready to start pacing, because after this, the LV forces will kick the graft back. So let's start pacing now. So we are pacing at about 150, 180 per minute. It's not increase the output. Okay, my left hand is keeping release the free flow. Yeah, so we have deployed the graft. Now stop pacing. Now we look at the pressures, and all the pressures are about same, about 120 to 130. So that tells us that we have good flow through the nominate penetration and the left carotid penetration. Comparison is with the femoral artery pressure, so they should all be the same. So they're all same. So we've finished this deployment, then we'll now take the delivery system out, and then we do the cannulation of the penetration. So we'll show you that in the next thing. So we'll. We can show the screen now. So we finished deploying the endografts and removing the delivery system. And we also have removed that Lundquist wire on which the system went. And now we have that loop wire which is going through the two fenestrations, and both ends of that come out of the femoral artery. So over this we bring a big sheath, 18F sheath, and then on the subclavian side of the loop, I've brought a 6 French diagnostic catheter and taken it over the wire through the left subclavian penetration. You can see the tip is just peeping out of the left subclavian penetration. And then I've passed a thermo wire parallel through this catheter, and that wire has entered the left carotid artery. So you can see the tip of it in the left carotid artery. And then we also have that existing marking wire loop in the left carotid to left radial. So on that, I'm tracking a 4 French catheter from the left radial sheath. So you can see that catheter coming from the left radial sheath, and it's going on that wire loop. It's now entering the left common carotid artery. So it has reached the left common carotid artery. And I think we'll pull that sheath a little back so there's some more room there. Yeah, so now we'll break this wire loop and bring a snare. So we're bringing a small, just release that wire, please. Yeah, take out the wire. So we removed that marking wire loop, and we're bringing a snare from the left radial axis 4F JR catheter. So the snare is, you can see the snare coming. It's entering the left carotid, and it's opened in the left carotid. So keeping it there, this wire from below will try and pass it through that snare. And yeah, so it might have gone through. I'll just close the, yeah, we have caught that wire. So now I'm going to pull on this 4F catheter from the radial side, left radial side. And this is what we call the rendezvous technique. So as I pull, you can see that wire loop is dragged into the, just feed it please. Is being dragged into the, no, feed, it's not coming. Not going in, just hold it. Yeah, okay, you can go live.
Sir, you are live.
Okay, so yeah, so at that point we were trying to exteriorize the wire going through the left subclavian penetration from the left radial artery. But what happened in that at that point was the wire actually went around some kind of a spicule in the aorta. So it was not allowing the catheter to track over it, and there was a lot of friction. So we then changed our plan. We came with the catheter from below, only on this wire which had been exteriorized from the, not exteriorized, caught by a snare in the left, that was axillary artery. And then we were able to pass a second wire which escaped that spicule and went cleanly into the left subclavian artery. And so this is that second wire which is now being exteriorized from the left radial artery. So the first wire we discarded. Next one. So now we've got the left subclavian fenestration wired. Now on the left carotid side of that wire loop, I've brought a guiding catheter, and now I'm trying to pass a wire up the left carotid. And this one, this one did not succeed going up. So from above, we managed to drop a wire down, and that fell into the endograft, and we brought it down into the descending aorta, abdominal aorta, and then snared it out. Next, so now we've got both the fenestrations wired from the respective arteries, and now we're bringing this covered stent. This is a fluency covered stent, 1040 in the left common carotid artery fenestration, and we deploy it with little traction on this wire. This wire is not a stiff wire, it's just the ordinary Termo soft wire. So, but by giving traction on both ends, you get the required support. And we project into the aorta by about 1 centimeter. So we'll have 3 centimeters into the carotid and 1 centimeter into the endograft, aortic arch endograft. Next
George,
one.
we'll have 4 more minutes for transfer.
Yeah, we're almost done. And similarly, we put a stent in the left carotid, the left subclavian. Next one. Yeah. And then we balloon both the fenestrations. Next one. And then that's the end of the case. So we did an angiogram, and we did not need to stent the left innominate because there's a good seal even without that. You can always stent it if required. And so you can see now that we have a exclusion of that PAU and a good flow into all the arch branches. And yeah, so now that's the end of the case. We just need to tie the proglides and pull out all the sheets. So any questions, I'll be happy to take them.
A round of applause from you, Dr. George, sir. Ajay Yadav this side.
Thank you.
And excellent case as always. So I think everybody's wondering, which are the major steps that you would say that are the most crucial ones? I think one is the left carotid artery marking and getting to deploy at that area. Is that so? Or
Yeah, so there are, I would say, 3 crucial steps. First is to plan it correctly. So you need to know the arch anatomy. And second is to transfer that plan onto an endograft correctly. And the third is to deploy it correctly. So if you get all these 3 right, everything is successful. Any one wrong, you have a problem. So while doing the procedure, orientation is the most important thing, both rotational orientation and axial position. If you get these 2 right, if your planning has been good, everything falls into place. Now, the question which everybody asks is, what if you're wrong? What if it's off target? And what if the pressure in the arch branches is not as much as in the femoral artery? Do you have any bailout options? Yes, we do. That's where this wire loop is very important. So we have this wire loop going through the carotid and subclavian fenestrations, and both ends are coming out of the groin. So if you gently tug on this, you can depress the superior aspect of the graft and then create a space between the graft and the aortic wall. And that will allow flow through the fenestrations into the arch branches. And keeping this tug, you can work and cannulate the fenestrations. And then once you put the stents, they will all align correctly. So that is why this wire loop is extremely important. It serves multiple purposes. Most important is, of course, to deliver catheters through the fenestrations and enter the target vessel. But second and equally important perhaps is the fact that if you are off target, you can very quickly, within seconds, get the pressure up in the carotid and the numbnet by just pulling down on the loop, and then you can work on that loop even while giving traction. Or you can come from distally and cannulate into the aorta. So we have multiple options, and then we have a gamut of these rendezvous techniques. You did one today, but you can go from any arch branch to any other arch branch. So tomorrow I'll be talking about that when I come over. So I think that's the most important thing.
Thank you very much, George, sir.
So George, not only have you shown such a exotic case, which we will have to probably go over it again and again to know all the steps, but you've also displayed how best to protect yourself from radiation. You have used all kind of protection for your headgear, for your eyes, and for your thyroid. So thank you very much, and to you and your team for putting up this beautiful case. A big hand for George Joseph.
Thank you. Thank you very much.
And I'll thank all the experts, moderators, and panelists for being part of this session. We take a short break for lunch. So lunch is served outside, and we'll join us again at around 2 o'clock, please, all of you.